Oh, interesting. Okay.
Oh,
Hi.
Hello,
started
hi.
you might have started the entire session,
Oh,
but that's okay.
to pause it.
We can record it because people are
Okay.
coming in anyway.
Okay.
Let me go live on Facebook. So we're welcoming people in right now. We'll wait until 10, just for the sake of making sure everyone can see. But welcome in everyone. Hold on, I need to figure out how to go live on Facebook now. How are you, Casey?
Good. Yeah. I've been traveling a lot, so just back home and small things. So I'm just now catching up on my rest, I feel like.
Oh, okay, yeah. Where are you from?
Yeah. I am originally from Texas, but I live in Arizona now.
Oh, okay. That's
Yeah.
in my time zone, right? In the Pacific.
It is
Yes, where are
now,
you at?
right?
I'm in California.
It is now. It's so strange with the because Arizona doesn't recognize the time change. And
Oh,
so one part
wait,
of the year I'm an hour behind my family, and then another part of the year I'm 2 hours behind my family. So it's confusing.
I didn't know that they don't do daylight savings.
Yep.
That's so odd. America's such an interesting experiment.
No, literally.
I know Hawaii doesn't either. I didn't know Arizona was also part of that squad.
hmm I know like Arizona as a whole doesn't, but then like the part where the Navajo Nation is, they do recognize daylight savings. So like
Oh,
there's a little part that does, if I'm not
So just
mistaken.
that chunk, so just the chunk recognizes it, but the rest of the state doesn't. How wild
Yes.
is that? That's so wild. Okay.
I know. It's so funny.
I guess we're just doing whatever we want.
Literally. I love what you said, Amanda. We're just an experiment. Like,
I know, like what a funny little experiment this country is. Um, for better or for worse. Okay, I think
yeah.
what's 10 so we can go ahead and get started. Let me share my screen. Okay. All right. So welcome to our Disparities in Diabetes brown bag. If you follow us on social media, you probably have noticed we've been pushing out this content for National Minority Health Month, which is April. So here is our dedicated brown bag to this topic. Um, you already know the drill if you've been here before, but just if this is your first time on a brown bag, DPAC is a patient-led organization. We train people in the diabetes community on how to be advocates, how to tell your story, and we go together sometimes to talk to legislators, and we also prep people on how to go on the state level, local level to talk to their legislators individually. So those are our social media handles. We try to educate, inspire, and empower patient advocates, and we operate on legislation that is relevant to people with diabetes. That's type 1, type 2, everything. So these are our two featured speakers today. We have Anna Norton. She is the president of the Center for Sustainable Healthcare Quality and Equity at the National Minority Quality Forum. She is dedicated to improving the well-being of underserved communities through education and peer support communities. Ms. Norton has worked in the nonprofit sector for over 25 years as an advocate, fundraiser, speaker, and leader, and has created leadership programs, organized national conferences, and created a bilingual health outreach program, and authored numerous research articles on diabetes health. She's also a member of our DPAC board and co-leads the DPAC Health Equity Committee. Um, Kacey Creel was diagnosed with type 1 diabetes at the age of 7 and credits the success of her own diabetes management to involvement that she has had with the diabetes community. With more involvement in the community, she has discovered gaps that crucially need to be filled to help all people thrive with diabetes. This created the passion that she possesses to stop at nothing until more resources are created and more barriers to diabetes care are knocked down. She holds a Master of Science in Diabetes Education and Management at Teachers College Columbia University. And in addition to working as a nutritionist, Kacey works as the executive director for the nonprofit Diversity in Diabetes. So we're really grateful to have these two very distinguished speakers with us today. Let me stop sharing so that I can get started with the questions. Okay. So we're just gonna jump right in. Could you please tell us in your own words a little bit more about yourselves, and then in your own words tell us what is health equity?
You want to go
Sure.
first?
Yeah, sure. Thanks, Kacey. Well, thank you, Amanda, and thank you everybody for joining us today, and thank you for inviting me to be on. It's really, really an honor to be on a forum that DPAC has presented so well. And I'm really, really pleased and honored to have been asked to be a part of this. I think as both a patient and an advocate for people that live with diabetes, as a Hispanic Latina woman that was diagnosed over 31 years ago in a predominantly Hispanic community, that didn't necessarily understand, in my case, type 1 diabetes, in a hospital that didn't really recognize type 1 diabetes. Health equity is really tough to manage in communities where it's not very prevalent, especially in Black and Brown communities, which is what I was seeing. And so I think, as I became an advocate, not just for myself, but for other people that live with diabetes, primarily for women that live with diabetes, health equity became really important to me. And the work that I do today at the National Minority Quality Forum, and in communities became really prevalent and really, really became the forefront. And health equity is something that's really important when you think about communities and meeting people where they are and making sure that they're getting the kind of health outcomes and the health needs that they need to manage the disease that they're in. And in this case, it's diabetes, so that they're getting the medication, the treatment, the management that they need, and the education and the resources that they need to meet them exactly where they are in the disease, in the where they are in that moment of their disease. That's what that means for me. Diabetes is progressive, so it changes constantly. And so it's not one size fits all at any given moment in time.
Yeah. I love that so much about where they're needing to be met in that moment and how diabetes is progressive, where one day you could be doing great, feeling like you got this figured out, and then you do the exact same thing, and everything seems to be completely different. And so it's always making sure that people have the tools that they need in that moment. So with health equity, it's making sure that if they're needing access to a pump or to all the new other technologies and medication that we have, the day and age that we have now of the resources and the technology and the medication. I mean, it's so diverse of what we are able to use for our management. And so it's super important that everything that is available, including that, as well as just the knowledge of diabetes management techniques, whether it be like the traditional or non-traditional, there's so many different ways to go about it. So making sure that those resources and also that knowledge, and the community aspect as well is available to everyone. Because for me, like I said in my little bio, like once I was a part of the community, that's where I like learned so much about like management, and not just like going to my doctor and hearing what the textbook told them. And so being involved in a community, I think is a huge like piece of health equity as well, because I can share my tips with Anna or whoever, and then they can take that to their doctor and be like, hey, have you heard this? But without the community, you wouldn't really get that. So I think to me, health equity is just making sure that anything in the moment that you need, you're being able to get access to that for sure.
Yeah, that's super important. And that's like also just underscores why the community is such a big part of advocacy in itself, because we work as a unit, like to meet people where they are, as you said, Anna. So in each of your experiences, what disparities do you see when it comes to access, affordability, and quality of healthcare for people with and at risk for diabetes?
Well, definitely. I mean, I think in Black and Brown communities, it's health literacy. I think that's a huge barrier. I think we see some, bias, absolutely, when we come down to like a hyper local level, when we're talking to smaller clinics, people are not getting the treatment, and the resources that they need because of where they are, because maybe they're not getting the medical resources that they need. Maybe they're not getting the specialized treatment that they're entitled to, or that they deserve. And so I think that that is a huge barrier. And so, we don't know what we don't know as patients, all right, or as people that live with diabetes. And so I think it's really important as community members, um, that those of us that do know, that we share that knowledge, and that we say, like, this is what we're entitled to, this is what we demand, and that we share that with the people that don't know, so that when they go to their providers, they say, like Casey said, I learned this from someone else that has diabetes. Where does that put me? This is what I deserve, and this is part of my health equity. And maybe they don't use that word, right? Because that is a very, very loaded word, but they say, I have diabetes and I should have this medication, or I should have this resource, or I should have this pump, or I should have a CGM, and this is what that does. Um, and this is how it's going to make me live longer. It's going to make me healthier, or it's going to make me have better outcomes, and I'm not going to have these complications. And so I think that those are conversations that people learn so that they can overcome these barriers, and they wind up having better literacy when it comes to their health overall, and it transposes into their family members and their community and so on and so forth.
I agree for sure, the health literacy and also just education. Going back to that again of what is available. I love what you said, Anna, about you don't know what you don't know. And it's very true in diabetes because there is so many different ways to go about it. It's such a personalized condition that there has to be so many different ways to go about it because it is so personalized. And it's personalized day to day too. Like I said, like something could be completely different for me than what I did yesterday than what I'm doing now. And so it's super important to, I guess, also making sure that our healthcare providers are staying abreast of everything going on. I know that can be very difficult for these small town clinicians that may not have access to going to like these conferences, diabetes care and education specialist conference and stuff like that, and having access because maybe they have to juggle so many different conditions as well. And so just understanding that the doctor is not the expert in your diabetes and kind of having that curiosity to look more into what there is available. But something that needs to be a little bit more addressed is the access of information that we have to it, because you can't just go onto Google and say, how do I manage my diabetes? And so kind of focusing a little more on the accurate information that is out there for diabetes management too.
Yeah, I love that you say that, Casey, because like, if you go out there and, go to Dr. Google, you can get a lot of information that is factual, but you can get a lot of information that is not true, right? And
Yeah.
it's not going to be credible. And if you take that back to a physician that is already skeptical, and that may not have all of the resources available to them, especially those in communities that are lacking the resources or are lacking the infrastructure, right?
Mhm.
They may not take you seriously. They may just be like, this person is Dr. Googling it,
Yes,
and
yeah.
just say like, where are they getting this from? They're just getting this from, you know, wherever, and may just say like, I don't want to talk to you about this. So I think it's really important to find these resources that are credible, to go to places like ADCES, to go to places like the ADA, to go to places like DPAC that are vetted, that are factual, that are credible, you know, um, I have found, and this is a personal stories, that when I used to log things, before smartphones and before CGMs and before I had my pump, that I would log things and think about things and get a book and go to the library and read things, and learn about my diabetes. And then go back and talk to like a CDE. At the time it was called a CDE, right? But talk to
Yeah.
a diabetes care and education specialist, and I had those resources. I was fortunate to have them,
Mhm.
but then when I would go talk to my specialist or even my internist at the time, and sort of impart that I had a little bit of knowledge, that they were a little bit more adept to talk to me, and that we would have a two-way conversation, you know, um, and also that when we were not having a two-way conversation, I would say like, it's time for me to find a new doctor.
Yes, that one. That one, not being afraid to interview your specialist. I think that's a big one. How sometimes people do feel like, oh, this doctor, they know a lot. They went to school for so many years. They're the ones that, but I mean, that person may not be a specialist. So kind of not being afraid if you have that resource to interview doctors.
Yeah, definitely. I think it's very important that you guys mentioned health literacy and how that varies between populations, between communities, and that's why it's kind of the job of organizations like DPAC and then advocates to disseminate that information, because it's no one's fault that there are differences in health literacy. Um, so my next question is, why is health equity important, and how does striving for equity help the entire diabetes community, including people who are not affected by disparities?
I'll let you take that one first, Casey.
Okay, for sure. Um, the first thing that comes to my mind on this question is just we are so much stronger as a whole. Um, the first thing that comes to my mind is the debate between um like with type 1 versus type 2 and all of that when you get to the nitty gritty, but we're just so much stronger as a whole. And if we can come together, um then we're able to advocate for everyone. I mean, that's what it is. Like, we're trying to get everyone to have the access to these things. And health equity doesn't just affect people from their racial or ethnic backgrounds, but it's also like the social economic standard or status as well. And so at some point you may be facing your own like disparity in your diabetes management. And so if at this moment that you're not, and you're also advocating for it to just be available to everyone at an affordable cost, at an easy access to knowledge and stuff like that, then once you're finding yourself in that own situation, then it may be a little bit easier to get resources to help you out as well. So yeah, we're just much stronger as a whole. You never know what's going to happen.
Yeah. I mean, and I agree with that, Casey, like 150%. We are stronger together than we are apart. And it is very, very important that we are united. Type 1, type 2, gestational, every diabetes in between, all of the types, that we come together, collectively. Our goal is to manage diabetes the best way that we can, to have affordable, you know, uh, you know, affordability and access to all of the tools, so that we can manage diabetes and have the best outcomes that we can have for as long as we can have them, right? So that we can live as long as we can live with diabetes, um, and that we can provide the tools to as many people that don't have that, so that we can all be equitable, right? We're talking about health equity here, so that we can have whatever it is that we need at the time that we need it, at whatever level that is, right? Um, and so if someone who is not experiencing a health inequity can provide the knowledge and the base for someone who is experiencing that, that just helps us to become more level on that playing field. So that's why it's important for everyone to help sort of in this challenge.
And I think the beautiful thing about our community as well, like at the base of it, like we're a community. And I know whenever I am needing help with like whatever, I ran out of insulin in that moment and I'm not close to home, like I was in Utah last year and I was able to get someone I didn't know but from Instagram, like give me some supplies to help me out while I was there. And I think that's the beautiful thing about our community is like ultimately, like, we are here for each other and we do want to support each other. And so just making sure that like those efforts also go into the advocacy realm as well is just as important as giving me a vial of insulin when I'm needing it too.
Yeah, definitely. And I've also had that experience. I feel like everyone in the community has had that experience where it's like you run out of something and someone just comes to your aid and it's like no questions asked.
Yeah.
Like I mentioned at the beginning of this call, like America is so big and it's such an interesting little, experiment. And it's like we all vary so much in terms of our like communities vary in terms of how much the health literacy and knowledge they have of policy. Like some person could be paying out of pocket for their prescription and they don't even know that there are policies in place or like there are legislations that are trying to be passed that could help lower the cost of insulin, and that's our job as advocates to advocate for not just our friends and family, but like people out there who like are suffering for different burdens than we are and don't even know about what they could do to help.
Yeah.
So what are some of the actions that the diabetes community can take either as individual or organizational steps to advance such an important issue? And like, how do we as advocates make sure that everyone is at the table?
Well, I mean, I think that we can share knowledge that we have. I mean, one of the biggest things that's on the table right now is, the $35 copay across the board for insulin, right? So that's like a huge thing, and not everyone knows about that. For the last couple of years, we've been hearing about the staggering and debilitating price of the cost of insulin. Right, we've heard that. We've heard that in our community. It has been all over social media. It's been on the newspaper. We've heard that. And, there has been a lot of work that DPAC and DLC and other patient advocacy groups and patient advocates have done to help lower that price and put a cap on that. And there have been a lot of people that live with diabetes and that are insulin requiring that don't necessarily know that, that there is a cap. And so how do we get that message out? It's really important to get that message out so that people that are still paying, for something that is life-saving for them know that there is a cap. So it's our responsibility as patient advocates, as people that live with diabetes that have this knowledge to go out there and say that, to tell people that. And that just starts from just one conversation with another person that might be struggling to pay that or thinking about that. So that's one way of doing that. And I think that being able to share that expands beyond diabetes because there are other medications that are debilitating in cost that are outside of the realm of diabetes. And if we're able to come together as a community in diabetes to share information like that, we can teach other communities to do the same, and affect the price of other medications in the same way, and we're in an election year, and there are medications that are experiencing the same kind of cap, like that, a $35 or $40 cap of how much it costs. So I think it's really interesting that we have this power to do that. And to
Mhm.
explain how that works, when it comes to insurances and these price caps.
Yeah, I just want to jump in and give some background on that for anyone who might not be familiar. The $35 insulin price cap has been passed for Medicare beneficiaries. So Medicare, people who have Medicare insurance have a $35 cap on insulin. But what DPAC is trying to do is get legislation passed so that that can be applied to everyone under commercial insurance, so that everyone who takes insulin has a cap and doesn't have to pay exorbitant prices for their insulin. Um, and so yeah, that's something that we're trying to work on. And I think what you said, Anna, also relates to a question that someone had from the audience about they said someone with quite a few disabilities, including type 1 diabetes. I never fit into any one box, and they're wondering if there are folks part of this community that are working on the intersectionality of having diabetes and other health issues. And most providers are specialists in one area and don't realize diabetes can affect a lot of other things. That's totally true. Diabetes has so many like comorbid conditions and also just conditions where it affects other organs and ends up, with other conditions. And I think, well, part of what DPAC does is we are part of the PPPC, the Patient Pocket Protector Coalition, which is a coalition of different disease groups, which are all affected by the drug pricing system. So we do definitely work together with different patient disease organizations to try to advocate for legislation that really affects all of us. So just wanted to address that before sorry, I cut you off, Kacey.
No, you're good. You're good. Thank you so much for giving that background. And I think that's also important too to realize that and to talk about how that diabetes is just one thing. There are so many people that live with so many other things that aren't even connected with diabetes. And so being able to find that community, I know is super special. And so, um, but from listening to Anna, kind of talking about the louder that we are about, hey, this is unfair about our medication and how it can translate to other communities. It made me think of, I'm pretty sure Cherie Shockley said this in one of our People of Color Living with Diabetes virtual summit of making good diabetes trouble. And I think that's what our community really does well at is being super loud together to make that good trouble, to just push the status quo of, hey, this is not working for society and for people living with diabetes. What can we do to make this better for everyone, to make it affordable for everyone, and hopefully kind of translating that into other conditions, and then also translating that into our other things that we use. So I think it's important, something that the advocates can do as well is not ever, and I know we don't, but not ever getting complacent of, okay, cool, we got insulin down to $35. What's next? Can we get Dexcom prices down? Can we get pump supplies down? Like what's next? So always kind of striving for the next thing to make things a little bit better for everyone. I think it's important.
Yeah.
Yeah, it's definitely
That's a good point.
questioning. Sorry. And were you
No,
gonna
I
say?
was gonna say that that's a good point. That's a great point, Casey. Like to think like what's next to make it more affordable or more manageable for the general diabetes population.
Yeah, for
Yeah,
sure.
yeah, it's really questioning like why are we paying so much for these things that we need to live? So it's like coming at it from it's not, entitled to ask for more. It's actually why is the system even like this? And like we're trying to, change what we feel like it's an unfair, situation that's set up. Um, I wanted to ask, is this of importance to legislators, especially when creating health policy? How can we as advocates ensure that we underscore the importance of health equity when talking to members of Congress when we advocate?
Well, of course, it's really important. Again, like this is an election year, right? Not just the presidential one, but like our legislators are vying for seats too,
Mm.
So this affects, us on a state level, on a community level, our cities, our precincts. So yeah, it's really important for community members to go out there and see, well, what are their community leaders in favor of? Are they in favor of their healthy communities and the people that represent them and the people that give back to their communities and work in their communities? And how healthy are they and how happy are they?
Mm.
And so yeah, it's really important. Like, what does your representative want from you? And how healthy are you? And how healthy do they want you to be? And how happy do they want you to be, and how much are you contributing to your healthcare needs, and does that affect how much you're contributing to your supermarket, or how little are you contributing to your
Mm.
supermarket and other businesses in your area because maybe you're spending more money on your healthcare needs, right? So it all boils down to maybe finances, right, in your community. So that could really affect your vote.
Yeah, and I mean,
Mm.
it's their job to please their constituents. That's the entire
Hmm.
reason they're in office and they want to get reelected. So they really want to make their constituents happy. And you keep that in
Yes.
mind. Like that is their job to listen to you.
Yeah.
Yeah, I agree. And whenever you were saying that, it made me think of how you were talking about like before CGMs and before everything that we have, like the research that you would do over your own diabetes. And so kind of researching the people that is going into office for us, and then not being afraid to have those conversations with them either. I think sometimes it can be a little scary to talk to legislators or, people of higher power, but like you just said, like that's their job to talk to us. And they want to hear from us. Like a couple years ago, I was able to go to a couple of Hill days with DPAC, which was amazing. But just doing that like taught me like they're just normal people that want to have conversations. They want to know what's going on, and they have staff full of people who are normal people that want to hear what's going on and that have similar stories of things that I was sharing as well. And so you were able to kind of connect. So not being afraid at all to have that conversation, start that conversation with them, and kind of share your own story as well as the stories of like other community members that may not reflect what you've been going through, but it is something that you've heard like another friend has went through and stuff like that, because we are so diverse. So and we can't all go to the Hill and everything like that, but I think the job as advocates is making sure that we're getting as many stories as possible and as many experiences as possible, to be able to share the diverse stories that are out there with people living with diabetes.
Yeah, definitely. And that's a huge part of making sure everyone's at the table is carrying not only your own story, but carrying the stories of your peers, your community. Um, and so my next question on that note is, what are one or two of the most memorable or effective health equity related statistics or talking points for people with diabetes to tell their legislators? I can start with one that have on our socials, which is when comparing people at the same income level compared to white patients, Black and Hispanic patients are offered diabetes technology at a significantly lower rate, which just is completely obvious that it's racial bias comparing at the same income level, people, it's not an issue of insurance. And that's a very powerful statistic that I think I carry with me when I would be talking to a legislator.
Yeah, I would say that, and I would say in my own personal experience, I wasn't offered an insulin pump for many, many years. And I know that that's just because of the community in which I lived. That's a health inequity right there and then, and that was years ago. Um, and I know from a panel that I moderated just a couple of years ago, there was bias in offering CGM, just because of the color of people's skin.
Amanda, you stole mine. Mine is always the one where it talks about how I mean, I have it pulled up right now because the numbers are just crazy. How for African American pump usage, there was 25% of people that used pumps, and then white patients, it was 61% of people who used pumps. But then you correlate that to diabetes management, and it shows that the average A1C for African Americans was 9.6. And then the average for white patients for A1C was 8.4. And just to keep throwing out numbers, but I mean, that's a 1.2 gap range in an A1C. And so I think holding that is super important. And then to have a conversation with that is making sure that the the advocacy around referring people always, kind of quieting that implicit bias, but just simply referring people to a diabetes educator or to a pump or to a CGM, even if like your implicit bias, which you're going to have, is saying that this person's not going to follow up or whatever for whatever reason, just quieting that and simply referring everyone always. So kind of using that status or that statistic in that conversation while you're going to legislators.
Yeah, that's really just perpetuating some of the issues that are existing in society. I think someone in the comments was also mentioning that he has never been, my fiance has type 2, I have type 1, he's never been offered a CGM or any help. That also underscores the bias between type 1 and type 2, which we know both are disproportionately represented in the communities of color, especially type 2. And for people with type 2, there's the compounded bias of, oh, well, they're type 2, they might not need this technology as bad as type 1 do. It's just like a compounded bias for so many communities.
Yeah,
Um,
yeah, and even in the like a pre-diabetes diagnosis, and if insurance might even cover a CGM for someone with pre-diabetes, and they're not being prescribed a CGM, which could, save an insurance company thousands of dollars, to avoid a type 2 diagnosis later, right?
yeah,
And so physicians might not even offer that, um, that option, which could really avoid so many complications later.
yeah,
And there's a bias there, right? Well, like we're not even going to offer it, just come back. And I've heard stories, from people like that, like you have pre-diabetes, just come back in a year and we'll see what happens. We'll see what happens. Like, what does that mean?
yeah, yeah.
Right?
It's
Yeah.
a health system, the way that you would think that preventative care, spending money toward preventative care essentially cuts costs because it prevents emergency room visits and all these like emergency things that you'll have to, but the experiment of the United States as we go back to that. So our last question, I know we're over time, but can you give us an example of how we might approach health equity in a conversation about, for instance, insulin copay caps, which is what we mentioned earlier about the $35 Medicare cap, and how we would like to expand this to everyone who has commercial insurance.
Well, I think that from our perspective as advocates, and from a DPAC perspective, and anyone that's listening here, there's over 50 people that are listening in. I think it's just to share this with anyone who is, um, either on insulin or struggling to pay for their insulin, who doesn't know, and let them know that there is a cap, and
Mm.
to let them know, to tell people that that's one way to start. To let them know that this exists, and ways to address that with their pharmacist or their mail order, plan, if that's what they have, and to let their prescriber know that this exists
Mm.
as well. I think that's where to start, and then go from there. Um, certainly we have to start someplace. If you don't know, you don't know. So certainly start there.
Yeah, I think that's a really good start. And then I know for me, sometimes I forget to do my own research as well. So kind of diving a little more as into that and what the nitty-gritty part of like that copay is and kind of figuring out what else there is that you can do as advocates to progress that conversation. Because for me, sometimes going in, like if Amanda and getting the information from DPAC, I wouldn't have known like the other parts of the, that we're trying to get the $35 copay to everyone. Like I would have thought this was just, for everyone, didn't really know the details as well. So I think sometimes not forgetting to do like that own research to understand like the small details, because there's always that fine print. So kind of understanding that, so then you are able to go to your pharmacist or physician whenever they do have a question back. You're not like, oh, I already gave you all the information I know. So trying to learn all of the fine print that you can so you can be actively involved in that conversation.
Yeah, and that's what we try to do. I feel like this is the kind of feedback also me as like a person who has diabetes and organizes the communications for DPAC. It's good for me to hear what people don't know so that I can help coordinate what we tell our audiences. So thank you, everyone. Let me just pull up our final screen here. If you want to follow us or become a champion, let us know. Thank you for joining us, Anna and Kacey, for this talk. And I'm sorry, everyone, that it went over, but we covered some really important topics. And I'm really glad that we had your expertise on this call.
Thank you.
Thank
Thank
you
you all.
so much. Yeah, thank y'all.
Thank you, everyone. Have a nice day.